Welcome to TCCC-Plus Day 2, Module 6, Respiration. This module repeats the lessons about chest injuries, vented seals, and recognizing tension within scope. Most breathing problems show up after the point of injury and worsen over time. The common perception, which we are often guilty of teaching, of the sudden, massive tension pneumothorax is uncommon, and overtreatment can do harm. Most chest injuries need simple measures or none. The boring intervention is usually the right one here. The dramatic one is rarely needed and often missed. And again, reassessment and prevention is often more important. For respiration, better or worse is the trend in rate, effort, and distress. Catch tension and pneumonia early. Respiration problems evolve, so reassess according to the 5 times. As we spoke about on day 1, we assess respiration by rate, chest rise, effort, pain, and distress. Furthermore, we inspect the chest for injuries, flail chest, and problems with previous interventions. This may include clogged chest seal vents or NDCs. New things to assess in a PFC setting is cough, coughing up slime or blood, or nasty sounds like rattling or wheezing. Pneumothoraces or collapsed lungs need an explanation. The lung sits in a sealed sac, the pleura. Put a hole in it, and air or blood collects between the layers of the pleura and starts squeezing the lung. If that hole acts as a one-way valve, pressure builds and becomes a tension pneumothorax. A tension pneumothorax is an emergency with or without an external wound, which needs immediate treatment. For an open, sucking chest wound, we can put a vented chest seal on dry skin. If breathing worsens, we can burp it or replace it. Otherwise, reassess and replace as needed. In general, tension shows as worsening distress, a climbing breathing rate, air hunger and anxiety, and a falling level of consciousness. This image shows the tension valve, revisited for the longer fight. Air in, no air out, causes pressure to climb until the heart cannot fill. In prolonged care, you may watch it develop slowly, and the fix is the same. Seal, watch, and decompress if it builds. Needle decompression is a stopgap measure for tension pneumothorax and protocol gated for good reason. A needle in the chest is a bridge skill and a blind one. Recognizing the problem is the job at your level. The procedure is by separate training and authorization. If you have not been trained and authorized, recognize it, sit them upright, and call telemedicine or escalate. Most chest injuries, in fact, do best with positioning, warmth, pain control, and reassessment, which is most of what a hospital would do too. We will also encounter a new PFC-specific problem. Over a long hold, a casualty who lies still, in pain, with a chest injury, will drift toward developing pneumonia or pulmonary embolism. Shallow breathing and lying flat collapse the small airways, atelectasis, and that seeds infection. Watch for fever, a productive or wet cough, faster breathing, a rising oxygen need, a casualty going off. Prevent and treat it by sitting them up, giving pain relief so they can breathe deeply, encouraging deep breaths and coughing, and keeping them moving. Then antibiotics by protocol and telemedicine early. Pulmonary embolism, or a blood clot to the lung, can be prevented by regular movement. So let's recap. You assess, seal open wounds, monitor, treat findings to the algorithm, and hand over. Respiration problems evolve, so reassess according to the 5 times. Thanks for watching Module 6 of the TCCC-Plus course, Day 2, Respiration. Next up is Module 7, Circulation.